here towards the end of the conference on a Saturday. Testament to Dr. Raymond, not to me, that's for sure. So our next session is terrible triads and other elbow problems. We have an excellent panel. We have Professor Ray Pensy. He is a professor from shock trauma, a true associate. No, you are a professor, trust me. A true upper extremity trauma surgeon. He soup to nuts, he does everything, flaps. He's an unbelievable trauma surgeon. I've learned a lot from him over the past few years, and he's been a participant here at this program for the past 2 years. We have Dr. Fuller from right across the river in scenic Camden. He's the program director over at Cooper. And we have Hesham Abdelfattah, who is one of the attendings, upper extremity attendings here at Temple, part of our panel. So our young gun, our stud, Dr. Abdelfattah is helping us along today. So once again, here's our participants. And our goals of this session are really it's a case-based review on elbow instability and elbow topics. It's to understand the terrible triad and complex instability patterns, but due to the nature of what our participants are here, we have many more students and residents that are participating, which I think is great. You are the future of orthopedics. So it's more about understanding basic concepts, learning learning what the natural history and the injury truly is and identifying it so you can preoperatively plan for success. While you're in the operating room, have an algorithm and techniques to maintain intraoperative and post-op stability, and to discuss a simple post-op rehab to maintain stability and to give people functional elbows. So what truly is complex elbow instability? It's an ulnohumeral dislocation with an associated fracture of one or all of the bony stabilizers of the elbow to include the proximal ulna, the radial head, or the distal humerus. So case number one. We have a 67-year-old female. This is her dominant left upper extremity. She is physiologically much, much younger. She's involved in weightlifting and horseback riding. She fell down the stairs. She's thin, she's female, she's 5'2", 115 pounds. In the trauma bay, she has an LC2 pelvic injury, which required a sacroiliac joint screw at some point, and this is her dominant arm. So usually the ER physicians or the traumatologist basically tell you, this is the only view you get down here, treat it. So Hesham, with that one view, which is truly no view, what do you think about it? Anything that jumps out at you?
I'm having a hard time kind of making out that x-ray from here, but it looks like there's a posterior lateral dislocation of the elbow. I can't see any obvious fractures, so you want to make sure they're neurovascularly intact.
Yeah, closed neurovascularly intact. Looks like a simple posterior lateral elbow dislocation, but for all the trainees here, do not get strong-armed by a trauma attending or by an ER physician to make you come down and do something to it. You obviously are going to get some additional studies, so lateral and oblique views, some additional films. Dr. Fuller, I don't know if they project well. Anything that you see that can make you diagnose what type of injury this is?
Well, you start to get a sense that there's bony injury too. The radial neck's broken, and there may be some injury to the trochlea. It's hard to tell.
Very good. So see something right here. If you had just the AP and lateral, that's very subtle. You don't see any radial neck injury. You maybe see some crumbs over in this area. So you do have a posterior lateral elbow dislocation. Looks like a complex dislocation. Good pickup on the radial neck fracture here. So Dr. Pensy, when you see a film like this in the trauma bay, do you recommend immediate reduction? Do you have your residents do it? Do you have the ER do it? Do you get upset if the ER does it? How does it work in your facility, which is an obvious different place than most of where we work, but what about in your facility and your recommendations?
So complex elbows, anything involving a fracture, I'd be upset if the ED attending staff did it. The resident staff would very commonly do that reduction for me, and I'd be okay with them doing so. I think it's important to get x-rays prior to reduction. Oftentimes, the John Wayne will come by and grab the extremity and relieve pressure on the skin, but at our trauma, it takes 15 minutes. It's not an hour. Mm-hmm. So I recommend getting good injury pre-reduction films on anything that looks crooked. It's going to help you assess the pathology. It's going to help you assess where you need to buttress plate, et cetera, right? So I think this needs a reduction. It needs a reduction as soon as you've got injury films and you've got somebody willing to give analgesia.
All right. So the ER attending reduced it. The resident was up in the OR. They didn't want to wait any longer, and now we have this. Hesham, what do you think?
So I think I would probably get some additional imaging. That's not obviously completely reduced, and it's going to be a little difficult based on the injury to probably get a concentric reduction. So I'd start off with some advanced imaging like a CT scan.
So it's not concentrically reduced because now we have a,
Bony fragment intra-articular, that's probably the
exactly.
capsule.
So the radial head and neck is now displaced,
Right,
and you start to see some additional crumbs in that area.
yeah.
So there's our AP. Anything concern you about that post-reduction film, Dr. Fuller?
Well, it's not reduced. There's a medial facet of the coronoid
There
that's
we go.
broken.
So, little medial facet coronoid fracture also. So what are you calling this, and do you guys need anything else? So Dr. Pensy, what are you going to call this injury? Real quick, one sentence. And then
Terrible triad.
Terrible triad injury. Anything additional on this terrible triad that makes you worry or more nervous or more, what are you going to have available for your operative fixation?
Yeah, the medial facet.
Yeah, medial facet makes you a little more nervous, or just have a little heightened sense of urgency in the operating room to get yourself prepared for it. So yes, we do have a CAT scan. 3D reconstructions were not done. They fight me a lot at this institution. So here is our CAT scan. So give you any more information?
No.
Okay, exactly. So
I mean,
it's exactly how I would answer it. Absolutely not. So
Personally, I don't even think the CAT scan was necessary. I
Exactly.
think we got way too many CAT scans, and more recently we've been sensitive to radiation exposure, and I mean, she's 67, but does every
correct.
22-year-old with this injury need a CAT scan? And I know you got different opinions on that.
I agree. I think with those films, you don't really need one. I know everyone does it. For some reason, we're not projecting, but this is a terrible triad. So elbow dislocation, coronoid fracture, and radial head fracture. You'd have a high index of suspicion. Sometimes you'll see little flecks of bone, which are actually truly fractures of the coronoid or the proximal ulna. These are at a high risk for chronic instability. And why is it called a terrible triad? First of all, back in 2002, Ring and Jupiter wrote a paper, a landmark paper, a seminal paper in regards to 11 patients with this injury that did poorly with certain types of treatment, and reductions cannot be maintained with a splint alone or even in a cast. A number of portions of the elbow column are affected in their pathology. You have to address all aspects of the injury when treating it surgically. You need to minimize iatrogenic trauma to avoid HO, and you may need to consider adjunctive measures to prevent post-op stiffness. So surgical planning, implants, position, anything else. So Dr. Pensy?
Yeah, mini fragment fixation is a stalwart of my operative plan. So little fragments of bone like the medial facet, I want even a modular handset available to address things like that. Supine. The nice thing nowadays is the HemoClear tourniquet. I don't know if you guys have used that. This is a sterile tourniquet that's a single line, and it doesn't have the same width. So in some arms, you can roll that up and get really great lateral exposure. Anything else? I think that there is role in my practice now a little bit more for things like the internal joint stabilizer or other external fixation methods.
So are you going posterior in all of these?
I go lateral on all of these. I guess if I were to see a medial facet I'm undecided in this. I mean, it's going to be interesting to see how it turns out. Any larger of a medial facet fragment in a younger adult, I would go posterior, but 99% of them, I'm going lateral, because that's where you get most of your business done anyway.
Yeah, I think if I have any concern that this might be unstable despite my fixation, then I might go posterior with the
Okay,
thought
so-
of potentially using an internal.
Dr.
anesthesia.
Abdelfattah will possibly do a utilitarian approach to get to both sides of the elbow. Dr. Pensy will go all from lateral. Dr. Fuller?
Fractures, I almost always come in from the back, so the patient's lateral. But for these, this is primarily an instability case in my mind. Even though there's fracture there, it's instability with associated fracture. And if I have instability, I usually like the patient supine, so then I can make medial and lateral incisions. Almost always starting
So you-
laterally
So if you were to go medial, you would make a separate incision. Good.
for an instability case, yeah.
So terrible triad, I did her supine. I used a lateral Coker incision, Kaplan approach, removed the radial head, started working on the coronoid. I used a suture anchor lasso technique. I used double loaded anchors. I was able to gain enough access due to her small stature for the anterior coronoid and the anteromedial coronoid fragment. Radial head arthroplasty was available, and due to the comminution in her age, I did perform a radial head arthroplasty. I then used suture anchor fixation in the LUCL and extensor mass, and she was grossly unstable throughout the entire procedure. Intraoperatively, once again, her entire distal humerus was bare. She was very unstable. I had a fixator available. In this case, I had an internal joint stabilizer available. I was worried during the case that I would not be able to maintain her stability. So I passed all my sutures through the coronoid. I then put my radial head in. I then put in my suture anchors for my lateral sided repair. I passed the sutures through my ligamentous and musculotendinous structures. I then placed my IJS pin just in case I was unable to maintain stability. I did a systematic repair based upon the anatomy and the way that natural elbow instability goes, and then I crossed my fingers. Examination under anesthesia intraoperatively was stable through full range of motion. There's fluoroscopy and almost full extension. I checked it again, and twice on Sunday there was no crepitus, and I was very happy. So thoughts on those intraoperative fluoroscopic pictures, Dr. Abdelfattah, and your thoughts on going through cases like this?
From what I can see from here, it looks like it's a fairly concentric reduction. I can't really tell about the size of the radial head replacement, whether it's
20 head,
I mean,
0 neck.
looks fine. I mean, I think my approach would probably be would be the same. I mean, I agree with putting the pin in for the IGS just in case, because coming back and trying to do that once it's unstable and you have everything in is a little bit more difficult to do.
Dr. Pensy, any comments?
No, it looks great. The problem is she's got a pelvis fracture. And she's going to try to pee at 2 o'clock in the morning, and she's going to use that on the weight bear.
Right.
So as soon as you throw a concomitant lower extremity or pelvis injury in conjunction with a terrible triad, your number 5 ethibond and the suture anchor are like pissing in the wind, right?
Mhm.
As soon as she tries to weight bear, which she'll do, because maybe at your hospital they run over and help her to the potty at 2 o'clock. Mine they don't.
We'll get into that later. We'll get into that later. So post-op course, real quick. When do you start range of motion, Dr. Fuller? Let's say she had no pelvic injury in that injury.
My preference is to start right away. I think we've learned from simple elbow dislocations that the sooner they move, the better. And I use those principles for these unstable elbows with associated fractures. And so I like to leave the OR with them in a sling and tell them to start active and passive flexion right away. So they're flexing from 90 to 120 or more immediately post-op day 1, and then sort of gravity gentle extension. So that's my rehab for most of these. And partly that needs me to have confidence in what I've done intraoperatively.
Dr. Pensy?
No, I agree. I splint anything with a ligament repair. I tend to splint, and I start range as soon as I can, gravity neutral. Hand on a tabletop, right, or straight up and down. The thing that drives me nuts, the patient comes back and says, "Look, doc, look how good my elbow's doing," and you're screaming your head off, knowing that your LCL is about to pull out of the lateral side of the
So
elbow, right?
you move them soon.
As soon as I
Overhead
can.
protocol, anything in particular with your protocol?
I'm sorry, overnight protocol?
Overhead protocol?
Overhead, no, the extensor mechanism I don't think is the problem. I might limit their extension
Okay.
to say 45 degrees, increasing 15 degrees every week thereafter, just to make sure they're not having someone try to straighten them out all the way, right away, but not really, just gravity neutral.
Who uses steroids in your Talbot triads? Nobody? So Journal of Hand Surgery out of Wake Forest. Nobody uses steroids, hasn't noticed a difference. So pre-op glucocorticoid administration improves elbow motion in terrible triad injuries. They gave an intraoperative dose of Decadron and a post-op Medrol dose pack, and they found that it decreased their stiffness. So no one here on the panel uses steroids or Indocin or anything in particular. Any routine HO prophylaxis for patients like this? What if they were recurrently unstable, had 6 different reductions? Yes, no?
Yeah, probably.
consider it
Revision
then, yeah.
surgery, yes.
Okay. Dr. Fuller, how often do you see these patients in the office? And how often do you radiograph them in the first 6 weeks?
Ideally, you want to see them once a week for about 3 weeks, and get x-ray each time, because we all know that there can be late instability, I think maybe 5 to 10%, when you repair these unstable, complex fracture dislocations. And I don't know that you always need an x-ray on every visit. Sometimes you get a sense of how well they're moving, but I think you want to see them weekly for at least 3 weeks.
So once a week for 3 weeks?
And unfortunately, as already pointed out, a lot of them are polytrauma, and then they just disappear. They have a pelvis and a tibia, and they go to rehab, so you're not seeing them back for 4 weeks, and I think that's a real loss.
Yeah, I agree. I see them at 1, 2, 4, and then every month or so after that until I'm comfortable. So I usually spin them for about a week if there's any ligament injury, and to protect the wound a little bit, and I get them moving at that point.
So our teaching points are systematic approach to surgical technique based upon pathoanatomy. You always want to fix the coronoid, even if it's a small little fleck, and there's a variety of techniques, whether it be K-wires, threaded K-wires would be suture anchor, lasso, drill holes, screw or plating techniques, fix lateral structures properly, including the extensor mass, because 60% of the time with these types of injuries, the extensor mass will be avulsed. Always have a fixator available. There used to be a stat that 5 to 10% of all elbow instability will require fixators in the operating room. I don't know if it holds for, really truly holds clear, but you don't want to have your pants down when you have someone who continues to be grossly unstable in the operating room. If you're going to do a fixator, put your axis pin in early, not after the fact, because then you're going to be drilling right through your ligament repair or reconstruction. Trust your repair and try your EUA before you're be bailing to a fixator. So in this circumstance, I thought I would have to fixate her, and guess what? She was stable through a full range of motion. And the question is, have we abandoned going medial? Real quick, Ray, if this lady continued to be unstable, would you just IJS her or fixator her, or would you have gone medial and tried to repair?
It's awfully tough, right? I mean, not every terrible try is exactly the same, and there's differing various degrees of instability. But if I think that there's substance to the medial side, like I saw a fragment here, I probably would have gone medial on her. But that being said, again, a concomitant injury makes me lean toward doing something other than just ligament repair, because those ethibond just won't hold up if she needs to weight bear early.
Funny part is last year I did the same panel, and everyone was going away from going medial and going right into a fixator and just staying lateral and fixating them and not having to go medial. So interesting. So case number 2, 42-year-old methadone clinic patient, fell down the stairs, down 12 stairs. This is his dominant arm. He presents to the emergency department with this injury. Dr. Fuller, real quick.
This has more of a fracture pattern. It's what we call a transolecranon fracture dislocation, where the humerus is just driven through the proximal ulna and the radial head's malvolar. But this tends not to be an instability issue, it's a fracture issue. So I think, you want to see a better x-ray of it.
So as you see here, radial head dislocated, distal humerus driven through the proximal ulna.
But this is generally a fix it and
right.
start moving right away.
Transolecranon fracture dislocation. The coronoid is frequently very large. You can fix the radial head through the olecranon defect where necessary. Most of the time, the capsulo-ligamentous structures are often intact, and this is a bony injury and not a ligamentous injury. And if you anatomically restore the trochlear notch in the proximal ulna, this will restore stability to the elbow. So here are some additional films. Professor Pensy, any comments?
Not particularly. I mean, I'm encouraged. This looks like this was a young patient. This is good bone quality. You've got a really great coronoid to work with. The radial head is not dislocated from the PRUJ. It looks like you've got a good radial head, so that you've got a great buttress, right? You've got the radial head and trochlea looking at a good buttress, the coronoid and the radial head. So for me, this is a posterior exposure over a padded Maya with the patient supine. And in that way, I can bring the elbow back down onto 2 arm boards together if I need to address some ligament on the medial side or do something else. Because sometimes it's hard to look at the radial head with the arm over the chest, so to speak. I worry about the PIA.
So nothing about this makes you nervous. So
the medial side looks bad.
Yeah,
You're
exactly.
going to have
So
to
for
take your
Hesham,
time.
here's his CT scan, 3D reconstructions.
Yeah, it's busted. So the hard thing is to try to reconstruct the joint, not shorten the joint and restrict the range of motion. So, I mean, I agree. I would approach it the same way, go posterior and plate the proximal ulna. And the hardest thing is just kind of reconstructing the articular surface. But you do have a nice anterior buttress.
So thought process. So we already have our 2 esteemed panelists who state they would go posterior they would do a posterior approach.
Yeah, I'd have the patient lateral, though. I'd do a posterior incision, but I'd have them lateral and come in from the back. And I like lateral because then when you're working, you can extend the arm, and that relaxes all those fragments. It lets them sort of come together. If you have them supine, I think sometimes things don't just lay as nicely when you're putting the
So
plate on.
you do them lateral, arm across a bump.
Right.
Dr. Pensy does them supine, but arm across a bump with posterior approach. Dr. Abdelfattah, same thing, supine, arm across. So sequence, any type of sequence of fixation. Ray, real quick, go through
Start
your
with the coronoid.
implant sequence, post-op protocol. Yeah.
Well, I guess the olecranon process, can you go back to your injury film?
Sure.
I think it's really neat, right? The way I think of this is an osteotomy. Your MCL and LCL are still generally attached to some of those bony fragments, and you can reflect the olecranon process just like an osteotomy. And then I start from distal, working proximal. So generally that means the coronoid, rebuilding that, and then the olecranon process goes back on last, so to speak. There might be transosseous sutures bringing MCL or LCL back, and before I tie them, I might put the olecranon process back, but generally, anyway, it's like an osteotomy for me.
So Dr. Fuller, in the implant selection, what do you have available in the room?
Well, you know you're gonna need some kind of long bridging plate, pick your company, but then often you need to supplement this with a medial plate. So you wanna have a modular handset where you can use a 2-4 plate, because the long plate, sometimes it's difficult to control the rotation, and as you're trying to co-op things with just one dorsal plate, things kind of shift at the last minute. So a small plate on the medial side, and I agree, I look at the coronoid first, and you generally end up lifting up the whole flexor pronator mass, and you're looking at that medial joint line to key things in, and you're looking right at this medial wall, the ulna, and it's easy to put a 2-4 plate there, or a 2-0, and then you put your longer plate on. And this one has a lot of comminution. You start to think a little bit about, and there were some reports on this, taking out some of that comminution if it's so bad you can't get a stable construct, and advancing the tip of the olecranon in, because the tip of the olecranon is usually pretty good. You have maybe 30 degrees there, and you can just kind of rotate that in and take out a little bit of the comminution. Easier said than done, but there are some reports about that.
Just what I did, I do my elbows prone, multiple fracture lines, sagittal and coronal fracture lines. He was reduced with multiple K-wires and reduction techniques, and I was able to tamp up his articular surface. And I did utilize orthogonal plating due to his significant medial column abnormality. And this is kind of what his fluoroscopic shots look like. So comments, Dr. Abdelfattah?
I think it looks good. I agree. I'm a big fan of the mini frag plating on the medial side.
That's a 2.7 mini frag medially, had good strong bone.
Yeah. Yeah, I think it looks good. That's the same way I would approach it for sure.
So that's his post-op x-ray.
When do you let this move?
When do I let them move?
Yeah.
I try to let them move as quickly as I can, but this is how Dr. Pensy did it. So, I do mine a certain way. Dr. Pensy did it here with 3, 4, 5, 6 plates. He's used 2.7 plates. He's used mini frag plates. He's used K-wires with tension band wire technique. So range of motion post-op, I try to move these young guys as quickly as I can when they get back to the office. And some of the older patients, the more the Montasias, I'll move them probably around 6 to 10 days. And I let them kind of fly more to what they can tolerate, because this is more of a bony injury rather than a ligamentous injury. And I hope that they get more range of motion sooner rather than later, as opposed to a ligamentously injured or unstable elbow. So teaching points, many different ways to skin a cat. So one person does it lateral, I did it prone, they did it supine. Bony reconstruction causes ligamentous stability in a transolecranon fracture dislocation. Be familiar with multiple different types of reduction fixation techniques. In teaching the residents, you present these cases to them, they tend to think of, well, we need to put one plate on, one pre-contoured plate on. Well, if you remember Dr. Chiadini's lecture yesterday, sometimes, you have to think on the fly. And don't just think you have to use a fancy contoured plate or one implant to fix this. You have many different ways of AO techniques to reconstruct your proximal ulna or your elbow, and that can assist you for many small little fragments, whether it's K-wire fixation technique, small threaded screws, headless screws, mini frag plates. One way isn't the only way, especially in these elbow instability cases. You need to have a myriad of ways of treating these, and by having a good pre-op plan and understanding the nature of the injury, you can be successful in the operating room. And for you to know, a transolecranon fracture dislocation, the radial head always goes anterior. So an anterior dislocated radial head, and the humerus is driven through the proximal ulna. It is a transolecranon fracture dislocation. So here we go, the pièce de résistance. 62-year-old morbidly obese female. She's referred in, fallen to an outstretched arm, and she had recurrent left elbow instability in the emergency department, according to the ED and the resident house staff. And she was admitted, treating orthopedic surgeon, and referred her in for me to evaluate. And these are her radiographs. So, Dr. Abdelfattah, real quick.
Yeah. So it looks like a simple posterior elbow dislocation based on these images. It's always the big arms that are unstable.
So
it's never the skinny old lady. It's always the big fat lady who's
Right.
terribly unstable.
So big arm, looks like a simple elbow dislocation.
Yeah.
Anything on that lateral x-ray make you concerned after the reduction, Dr. Pensy?
Yeah, she still has some
Moving like a
sag,
cat,
right?
yeah.
And I agree. This is failed prior reduction attempt.
Yes.
It might be simple. There might not be bony involvement. A CT scan will probably show you some tiny fleck of the radial head or maybe a small coronoid, but this is operatively treated at this
Yeah.
point.
So really not much reduction attempt, still a little bit of sag, simple elbow dislocation. And that's what her arm looks like.
Yeah.
That's her arm, not her hip, okay? So we're actually gonna fix her. So did a Kaplan approach on her, suture anchor repair of her LUC extensor mass, and she was stable through a complete arc of range of motion. That's what she looks like intraoperatively and postoperatively. So post-op course. So Dr. Fuller, you do that case, what exactly are you gonna do for this young lady, this track athlete?
Well, for me, this is a belts and suspenders case. This is somebody at really high risk for recurrent instability, dislocation. I think some things we don't talk about enough is looking at the patient's joint stability in general. Are they loose jointed or not loose jointed? I think any shoulder surgeon, is looking for somebody predisposed to redislocate. I'd look at other limbed or MP joints hyperextend, is their thumb hyperflex? And am I dealing with somebody that's generally ligamentous lax? And those people, even though you felt like things are stable intra-op, this is somebody that you may think about repairing things on the medial side. I think she's probably an ideal person for an internal joint stabilizer.
Wasn't available.
Well, but then, then you bring her back a couple days later and put it in. She's somebody.
Wasn't on the market.
And she's somebody that's difficult for an external fixator because of her soft tissue envelope. The humeral pins are really likely to pus out. And so she's somebody that I don't want to put an external fixator on. I'd really likely go on the medial side too because of my concern about recurrent dislocation with that initial surgery and see what's going on the medial side. And knowing that, even with the medial side of repair, she can redislocate.
So splint, cast. So IJS was not available at the time that this case was done. It was not on the market.
Well, this is one, I know earlier I said I want to move them right away, but if I don't have those tools, then I'm going to splinter and try and hyperflex her a little bit, but now that puts her at risk for compartment syndrome, but push her past 90 a little bit, 100. And, pronation, supination you can argue about, but she's not going to like a splint. It's going to be heavy with that size arm.
So no consensus for what you want to do. Good.
Well, I would protect this,
Okay.
which is the lateral side repair.
All right. So lost to follow-up, of course. Admitted it at another hospital. Ortho at the other hospital said everything looks good. Took her splint down, looked like a hip to me, took out her staples. I put her back in something, urged immediate follow-up and maintenance in her well-flexed splint. Called 5 weeks post-op. ED contacted me from another facility. She likes visiting various places in the area. She likes the food at various places. They tell me she's infected. Direct transfer initiated. No x-ray was done. Splint was off. Arms dangling, no sling. When I evaluated, the wound is healed, no infection. They're great clinicians in the ED, but this is what her films look like. Dr. Pensy, professor, now what do you say, if that projects?
Yeah, no, she's obviously recurrently dislocated. I'd be curious as to what her ulnar nerve is doing. And
She's actually neurovascularly intact.
I think she's still young, and you'd want to get her back in. She's going to have a better outcome with a concentrically reduced joint, and you need to put an external fixator on her. And I think an external fixator can be used as a splint. We often put external fixators, and we to bring the femur out to length, we leave it static. We want to keep them at length. But it can be used as a splint. It can be disassembled and supervised OT, provided you have the right OT and the right patient. But I share Dr. Fuller's opinion. Those pins in the humerus are not easily done, and that's not a resident pin to put in. That's a attending pin that needs to be put in.
So if you notice, if it projects, she's now medial as opposed to posterolateral, and you see some stuff over here, and you're starting to see some stuff over there. So you got some calcification, some healing. So she's now, like the young swimmer, she's a multi-directional instability. She's got thin, paper-thin skin. So now what? Thoughts, pathology, surgical plan, approach. What do you have available? So, Hesham, what are you going to do on this patient now? She's now 5 weeks out. She's now out medial. She's got some healing. She's enormous.
Yeah, these are tough. I've had one or two of these, and that's so this is going to be an open reduction. There's no way you're going to get this closed, and even if you get somewhere in the area, it's not going to be a concentric reduction. And oftentimes, even open reductions are not totally concentric, unfortunately. So I would go in, I'd clean out the joint, I'd get as close to a perfect reduction as possible, repair medial and lateral, arrange it. It'll probably still be unstable, and I agree. I would put it in an external fixator.
What type of fixator would you use?
Not a hinge, probably just a static.
So static X-fix. Yeah. So in regards to repair or reconstruct the ligamentous structures, Ray, do you have a time?
Timing? So I guess, You know, you had a prior lateral incision here, but if this had been posterior, and maybe even now, you can obviously make a circle out of a semitendinosis and go from all the way medial to lateral and get both of them with the reconstruction. I'm worried the MCL is obviously a very tenuous structure to begin with. And my getting a real repair of the MCL, I find difficult unless it's got osseous pathology with it and it's acute. This is not. And so I'm thinking there's a good chance I might reconstruct her with an allograft here.
Okay, so 6 weeks out, 3 weeks out, 5 weeks
Yeah,
out?
I think anything more than 3 weeks.
So 3 weeks, if you
Yeah.
get anything out past 3 weeks, you're thinking about a
You
reconstruction.
can use ankyneus fascia if
Right.
it's available and it's not previously dissected.
Yep.
Anna Murthy put that
Anna
out
Murthy,
there. I
yep,
like it.
and
It
Shibley,
works.
yep.
But
Dave, 3 weeks, 4 weeks, 6 weeks?
You don't have an infection.
No, it's not infected.
Yeah, I try and change the paradigm in my mind a little bit for these, and I start to think about fascial interposition arthroplasties and how difficult those can be, but they do achieve some good outcomes. And this is better than that because your joint surfaces are better. She has congruent surfaces, but you're kind of treating it like a fascial interposition arthroplasty. You got to get it reduced. You got to keep it congruent. You got to keep it tracking. And I've gone back and forth on these external fixators. Initially, I loved the hinges, but they're a little more work to put on. Then I started putting static pins on, but then I started having humeral pins ripping out and breaking because people want to move their elbows so much that they cycle those humeral pins. And so you go to these 5mm pins, but now you're putting big holes in the humerus. So I've kind of gone back to putting hinges on these, but I'm treating it like a fascial interposition where I can have better joint surfaces. I want not a unilateral frame for this big arm, but medial and lateral frames to stabilize this arm. So that's what I'm looking at.
Took her to the operating room, re-repaired her lateral side, went right to a large static X-fix. So we got a concentric reduction, maybe a little bit of radiocapitellar sag, but she's got her joint is reduced. So why static? Easier to put on, less fiddle factor. Habitus, she's enormous. Compliance. So I tried to think that I was really smart in trying to, eliminate her unsophisticated nature. And my plan was to keep it on at least 6 weeks. Anybody keep it on more or less?
no, I think 6 weeks is good. Did you allow her to unhinge it with an
No.
OT? So it was static, stayed in place 6 weeks?
Static, yes.
Did
So
you-
Go ahead.
I think that supination deficit is a real problem for some of my, and if you look at the literature,
Mhm.
aside from loose loss of extension, supination is the next worst outcome, right? And so although you might have her locked up at the elbow, at least you can work on supination
Mhm.
here. And I think for the residents and PAs, whether it be the distal radius that has an X-fix or a bridge plate, focus on supination. And similarly here, you can still move the forearm axis. It's not fixated.
So once again, IJS not available, and I don't know if an IJS in a patient like this, 420 pounds, the cost, whether or not it would have kept her stable anyway. So post-op course, remember that's her arm, strict non-weight bearing, has a terrible knee. She's 5'2", 420 pounds, non-compliant. Remember, that's her arm, not her hip. Get a call again. That's what we have now. Hesham, what do you think? You're glad it's my case and not yours?
Yeah,
Oh.
send it to you. Yeah, these are difficult. I mean, can't really see what's going on there.
So she's fractured through her
above the
superior
pin.
humeral
Yeah,
pin,
damn.
and she's now, her radiocapitellar joint is subluxed.
Yeah. So you need to do something. I mean, you need to fix the fracture. You may, this may be something that goes on to at least a temporary spanning plate of some
Yeah,
sort.
yeah. So you and I are gonna start drinking some arak.
Yeah.
We're thinking about this before you start to go in. So what do you plan on doing now?
I'd remove the X-fix. I would, I don't know, this is one that I have to think about for a while, but I'd remove the X-fix and I'd probably span the joint with a long posterior plate, at least temporarily, just to get stability, and then you can always take it off and deal with a stiff elbow later if you need to, but I think a stiff
Yeah, so-
elbow with a healed fracture is better than an unstable elbow in somebody with their body habitus.
Okay, so, or a humerus ligament reconstruction, what do you think, Ray, about that?
Give her a pin holiday. I think you need to give her a pin holiday. If you're putting metal back in her, take the pins out, splinter, caster, who cares? Her elbow's been dislocated 2 or 3 times already. It's floppy, whatever. Get the skin healed, give her some antibiotics for a few weeks, ORIF the humerus, and try again.
What about arthrodesis?
I've only done one arthrodesis in 10 years, and I think it's not a great option. The only
Okay.
time I've done it was huge soft tissue defects in an alcoholic who heavily contaminated elbow.
Right.
Everything else I try to save.
And tumor prosthesis TEA in this patient, absolutely not, right?
Condemn her to infection. She's going to get a PICC
Damn right.
line. You'll end up killing her.
So my prelim surgical plan was removal of the X-fix, ORIF of your humeral shaft, get a long, big-ass 4.5 plate that acted as an internal splint to get her stiff. So I had, I did my testosterone that week. I got the big plate bender out. I was ready to do this on her. I told her that you're going to get stiff, and you can get yourself a real long spoon to feed yourself. I don't care if you can't bring your hand to your mouth. You have another arm. So intraoperatively, she had a massive arm. She had intraoperative distortion of all soft tissues. I fixed her humerus, and I was ready to cross her joint with a huge plate. And after I fixed her humerus, I brought in the fluoroscopy, and elbow somehow was stable on fluoro. And I have the fluoro to prove it. So,
I haven't had an X-Fix pin break. I've put on maybe 15 humeral X-Fixes. I've not had that as a complication, the humerus breaker on a pin. Did she fall or anything else? No.
trying to push her arm up,
Yeah.
went to go grab her
How
cheesesteak.
far out was she when she finally broke it?
About 4 days out.
Just 4 days. That was
Yeah.
a 5 mm half pin.
Yeah. I used big pins,
Yeah.
right. And there she is at 3 months.
Center,
Maintain-
center, right? So sometimes you
Yeah.
go put a pin in and you're like unicorn.
I thought maybe did I keep my pins too close, but I mean, her arm was huge. The higher up I was going to get into the radial nerve, and there she is, healed at 3 months.
Mhm.
So teaching points of this case, this will be the last case, even simple can be complex. Even simple can be the sublime based upon body habitus and non-compliance, just like we all talked about yesterday. The IGS was not available. It may not have helped in this case anyway. Timing versus repair versus reconstruction. So 3 weeks may be the time that you want to consider about ligament reconstruction. But I don't know if this patient would be amenable for ligament reconstruction at all due to her non-compliance and her body habitus. Outside of the box thinking sometimes is needed when complications occur. And they occur to all of us, even the best surgeons. And sophisticated surgery is for sophisticated patients. So with that, the principles of treatment of elbow instability are restore and stabilize an ulnohumeral joint, so turn a complex problem into a simple problem, and then repair your ligamentous structures. You want to neutralize forces to allow for early range of motion. You can consider steroids or HO prophylaxis in your perioperative period to decrease your rate of calcification or range of motion issues. Progressive static stretching can start at around 6 weeks. And for me and for all of you, when you're doing elbow instability cases, have a fixator available for every case. And with that, I thank you.